Good morning, everyone, and welcome to Value in Health Week Wales. My name's Sally Lewis. I'm the National Clinical Lead for Value-Based Healthcare in Wales. Many of you will know that we had planned to stage our first international conference in value-based healthcare in Wales in November, but of course we have had to postpone that event due to the pandemic. So we thought we would stage a virtual conference instead. And I'd really like to thank my team in the Value-Based Healthcare programme and the Life Science Hub team also for helping us to stage this event, which they've really put together over the course of a very short space of time, having been redeployed for the COVID effort for most of the last 6 months. We have an illustrious panel to kick off a programme of very diverse events over the coming week. So I'd like to introduce our panel for you today. We have Professor Chris Jones, who is Deputy Chief Medical Officer for Wales, Professor Alan Brace, Director of Finance for NHS Wales, Helen Thomas, the Director of the National Welsh Informatics Service, Judith Paget, CBE, Chief Executive Officer of the Aneurin Bevan University Health Board, and Carrie Ann Quinn, CEO of the Life Sciences Hub, and they will each give you their perspectives on value-based healthcare in Wales. So now I'd like to hand over to Professor Chris Jones, Deputy CMO for Wales.
Well, thank you very much indeed, Sally, and good morning, everybody. Welcome to Value in Health Week, and for our international registrants, welcome to Wales, where we've been on a journey over several years of embracing value-based healthcare. This journey for us probably started in 2013, when our then Health Minister, Mark Drakeford, now our First Minister, discussed prudent healthcare as a philosophy for clinical decision making. Within that philosophy, there are a number of principles. Care should be proportionate to individual need. We should co-produce care with the patient at the heart of their decision-making process. We shouldn't over-investigate and over-treat where it's not added value, and sometimes less can be more. And so this has remained since then our philosophy for healthcare in Wales and been embraced by subsequent health ministers. I think, though, one thing we have found in Wales is that prudent healthcare in the form it was described was difficult to measure. And so although we were undertaking a number of pathway redesigns, a number of new approaches to care, it was very hard to measure the impact of that. And I think it is this desire to be able to measure and describe improvement that has led us much more towards value-based healthcare as a natural consequence. Clearly, value is such an important element of healthcare. We want to provide healthcare that delivers the best possible outcome for the person for whom it's designed. We want to provide the best care. We don't want to do healthcare for the sake of it, healthcare that sometimes may be no value or low value. And so to measure value requires us to measure outcomes. This may be clinical outcomes from audit data, or it may be personal outcomes from patient-related outcome measures. But also we need to measure the costs associated with those outcomes. And you'll be hearing more this morning about how we can use value-based healthcare as a means of looking again at how we cost the delivery of care, because clearly the same outcome can be achieved through various means, which have maybe very varying costs associated. So where are we now as we have this virtual conference? Well, we all are fully aware we're in the middle of a terrible global pandemic, which is bringing terrible suffering across the world. But I would argue that at this stage in the pandemic, we need value-based healthcare as our guiding light more than ever, perhaps before. We closed down all of our routine healthcare to cope with the first peak of coronavirus in the spring. But then as the pattern of infection has subsided, we've reintroduced healthcare. But we have found, of course, that there are challenges associated with this, the challenge of protecting people with non-COVID care from the risk of infection with coronavirus. And those infection prevention and control procedures have impacted on our ability to deliver care. The social distancing required, the deep cleaning requirements, the donning and doffing of PPE, all of this means that our capacity to deliver healthcare is significantly reduced compared to prior to the pandemic. And at the same time, we know that there are many people now waiting for care. Now, clearly, we have a massive backlog, people who did not present to hospitals during the peak of the pandemic, people who were not referred into hospitals, people who did not attend primary care. And we know now we have a responsibility to those people to deliver the care that they need, albeit within the limited resource that we can provide. So now, more than ever, I believe we have to use that resource wisely. And that does mean that we need to use our approach to value to guide our care. It would be wrong now to use that precious resource to deliver care that was not of the highest value to those for whom it's designed. We now need to use our resource to deliver the maximum possible benefit for those people that need health care. So at the moment, I do feel that value-based healthcare is more than ever an essential requirement. And so for me, this conference, this virtual conference, is ideally timed. We have over 3,000 registrants, something which would have been impossible under normal circumstances. I hope that this conference is enjoyable, but I hope it reminds us and raises our awareness again of the pressing issue of our time to deliver the most benefit from the healthcare that we can provide. We know that value-based healthcare engages clinical teams. We know that it brings clinicians and managers together. And I do hope, therefore, that we can, as a result of this terrible event, move on to a better set of arrangements as we gradually emerge. This is a disruptive event, and certainly in Wales at the outset, we knew that we would like our residual health economy to be different and better following the pandemic to what it was before. And I do believe value-based healthcare provides a mechanism for us to move towards that goal. So those are my remarks at the start of this wonderful conference, which I hope is a great success. I now pass on to my colleague, Professor Alan Brace, who is Director of Finance for the Health and Social Services Group in Welsh Government. Thank you, Alan.
Thank you, Chris. Good morning, everybody. Bore da. Welcome to Wales. And usually for me, I normally talk around the work that we're doing on outcomes, and to a large extent, that's been a feature of a lot of the work that I've done with the colleagues that you will hear from this morning. But today I'm going to concentrate on the other side of the Michael Porter equation, who often said value is the relationship between outcomes and costs. I'm going to spend a bit of time on my slot just talking a little bit about what we're doing around the money in Wales, and that very often doesn't quite get the attention, but if we're not careful, if we don't align this properly at a system level but also right down to a patient level, then money can become a real barrier to progress. If we get it right, it can become a real enabler. But let me pick off a couple of issues that I think whenever we talk about healthcare and money, the first area that everybody concentrates on is funding, and Wales is no different. I think we've had many years around what's the correct level of funding for healthcare? Are we spending enough? Are we spending it in the right place? And that's an important conversation and has been an important part of the agenda within Wales, certainly for this government, particularly as we came off the back of economic austerity and some of the problems that that created. But we've got to be careful as well, in the sense that I think increasingly over recent years, part of the problem has become more about the sustainability of our system, and particularly our ability to get a workforce to work in the system that we've created. And we've come to a stage where very often it's not about the money, it's about can we get the people to work within this current system. And is there sustainability that we can see in that looking ahead? The second area that I want to come on to is probably for me sometimes the most unhelpful debate about efficiency. Wales is no different to any other healthcare system. We've got a growing elderly population, a growing burden of disease, and increasingly, as that puts pressure on the current service model that we've got, the main objective at times has been the sort of chase for more and more efficiency. Can we actually deal with the problems of growing demand and an unsustainable service model by trying to make it more efficient? And we're no different in Wales than that. We have had quite a significant drive, I think, at all levels within the system on increased efficiency. But we are a publicly funded system, and I mentioned the health of the population. That generates demand for healthcare. That increases the volume of healthcare we deliver. And when you have those dynamics, you invariably get access problems. And the way that we've traditionally dealt with access problems is to try and become more efficient and to deal with the pressure that we've got on our system, particularly in terms of things like waiting times or our unscheduled care system, where we've got busy accident and emergency departments, by trying to make the processes that exist within those services more efficient. And the problem with that is that often been at the expense of effectiveness of the care that we give. And if we step back and compare the system in Wales with other healthcare systems internationally, we are a very technically efficient system. We are very good on our care processes because we've managed quite closely the relationship between the inputs, the financial inputs we put into the system, and the outputs that we get. And that drive to try and do more output with either the same input or less input has meant that we've been really good on the process side, but we've got really poor outcomes. Now, undoubtedly, a lot of those poor outcomes are driven by the health of the population. I think we've got a significant burden of disease that is bound to generate problems in terms of outcomes. But I think equally, the great push on efficiency at the expense of effectiveness has probably contributed to that. So the problem for Wales now going forward is not more efficiency. There will always be the requirement in any system to be efficient and to demonstrate it. The real attention now is how do we use the way that we manage our resources in Wales to concentrate on outcomes and effectiveness. And one of the problems that we've got, and I think you'll find this in all healthcare systems, there is invariably quite a significant disconnect between the way resources are allocated in the system to the way those resources are utilized in the system, and then how all of that relates to really good outcomes. And we are no different at a system level, so the way that we allocate our resources to our local health boards, the way our local health boards allocate resources within their organisations. And very often they will be disconnected from some of our more traditional measures of utilisation. They will invariably be the things that we measure are the things that we focus on in the way that we measure the utilisation of money. And they are invariably in the productivity and efficiency area. And then we've got the real issue is, do we genuinely understand how all of that makes any difference to outcomes? And they are good clinical outcomes in the sense that we want to be technically a clinically good system, and we want sort of really good clinical effectiveness. But equally, we need to focus on the outcomes that matter to our patients. And that brings us back to some of our population dynamics and some of our population ambitions. So you're going to hear a lot of good work this week about the work that we've done to join up the utilisation of our money with our outcomes, and some of that will be at a system level in cardiovascular disease and respiratory disease. You will see that in our work with lung cancer and diabetes. You will see a lot of work at a system level where we measure things like our spend on cataracts and hip and knee surgery. And you'll see that very much down at a patient level and a condition level. So on the utilisation side, we've got some really good insights into the way our system is utilising resources at a system level, at a condition level, and even down to a patient level. And we've got to continue that work and we've got to build it. But the important area that we're now paying our attention to is the way that we allocate our resources. The starting point for that is to try and develop a new funding formula for Wales, which is now in implementation. And we've designed that so that we can see it's invariably like all funding formulas in publicly funded systems based on the need of the population weighted for various factors. And we've designed it so that we can use that in the way that we allocate funding to our local health boards. We can also see below that level down to our local government level, which is increasingly important when we think about some of the broader determinants of health and the partners that we need to work with to address some of the needs in our population. But more importantly, we can also see that down to what we call our GP cluster level, which is smaller groupings of population, where we can see the relationship between the needs of the population at that level, but also the resources that we're currently allocated and where our mismatches are and where our gaps are. And that's been a really important foundation in terms of the development of sort of resource allocation in Wales. But the next bit is probably fairly uncharted territory, is how do we use that resource allocation process now to drive really good outcomes? How do we use finance as both a lever and a way of rewarding those parts of our system that are genuinely delivering the right outcomes to meet their needs of their population? And it's a tricky bit of work. It's pretty much, there's not a lot of evidence base where this has been done. We are not a market system, so we can't use market mechanisms and bundle payments and very sort of hospital-based measurement to do this. We are a planned system on a population health system. So we've got to make this work at a population level strategically, and it's got to lever and enable the right types of services within our health and social care system. And all of you who have joined the call who've been involved in any aspect of this work will know that that's very different when you try to sort of look at the way you allocate resources to something that feels a bit more straightforward, like planned care, to how you would do that in chronic disease, how you would do it in mental health. How do you do it when you move outside of the hospital system and into much more of the multi-partnership type approaches, working with partners in social care and the voluntary sector? So we've got a group now working on that. We're going to need some academic partners to work with, but if we can just get this last bit right, we will be able to more confidently look at our system at all levels and say that we can absolutely see the way that we've joined up, the way we allocate resources. We can be confident that as we allocate them, they're utilised really well, and they're utilised really well to drive really good outcomes for our population. And over time, we therefore should see the health of our population improve. So that would be a quick update from me, what we're doing on finance, but as you could probably tell, underpinning all of that work, we really require excellent data at a system level and right the way down to a patient level. And therefore, I'm really pleased to hand over to Helen Thomas, who leads the work nationally and works very closely with us on value-based healthcare, but gives us the infrastructure that enables us to do some of this work with confidence. So welcome, Helen.
Thank you, Alan. Good morning, everyone. As Alan has said, I head up the NHS Wales Informatics Service. And as a health informatician working in NHS Wales, I'm going to start by kind of reinforcing Alan's last point there about data being at the heart of value-based healthcare. And actually, I would probably argue it's probably quite impossible to move forward value in health and a value-based healthcare system without data at the heart of it. I think for me, working in NHS Wales at the moment, actually I feel really privileged as a health informatician because we've got a very clear policy and strategic backdrop, particularly around the data and information requirements to support taking forward value-based healthcare. The Health Minister's made a stated intent to use our health and care data for the better and to improve on that. We have data and digital quite prominently within our long-term plan in Wales. And we've also got a flagship programme to establish a national data resource, which kind of gives us the architecture and the enterprise that we need to take this forward at scale. So, I think for me, you couldn't wish for a better mandate to actually take this forward. But why is data important? Well, I reflect back to when Chris Jones was talking about the onset of prudent healthcare principles for NHS Wales, and I remember reading those and trying to understand those and thinking, absolutely, you can't take this forward unless actually you're able to measure these things, unless you're able to understand these things. So for me, data underpins all of our decisions across health and care services, so that whether that's data on the ground for individuals to support decision making for them and with them, or whether that's at a system level so that we can focus in the right areas and know that actually we're improving. So to take this forward, data is at the very heart of it. And of course, because if we can't measure something, how do you know what's happened? So what do I think it means for Wales? Well, I think it means a system that is data driven and data informed. And I'm not just describing lots of whizzy analytics, although I do like them, as you could probably appreciate. But this is about the whole system being data-driven, sharing and using data, providing insight and making informed decisions at every level. So from an informatics perspective, our direction is clear. We'll ensure we have the architecture and the platform to enable the environment that creates that insight. So this is not about collecting data for reporting. This is about actually using the systems and services that support operational running of those systems and services and the management of our pathways of care to ensure that that data is available for all users, both in real-time operational and in the review of that data and using that data for improvement. And actually, I think we could probably describe our system as being quite data rich, but I think we're probably information poor. And we acknowledge that, hence as having the policy and strategic backdrop that we've got to actually improve on that and to make that better. And actually, in my experience, the only way to improve data and the quality of the data that you have is to use it and to use that in anger. So I think one of the areas for us to focus on that is kind of pivotal to value in health is our outcome data, and we've heard that from colleagues already this morning, and that's about our clinical outcome data and our patient reported outcome data. And often that data is kind of locked away in silos in disease registries that aren't that accessible to the people who actually want to use it and want to use it to improve their services on the ground. So one of the main areas for us to focus on in the National Data Resource Programme is how do we provide that the facility, if you like, to record that data, often as part of the care pathway, and bring that data to life, but do it in a way that that data is usable and we can use it to compare and contrast and improve, but we can use it in everyday health and care settings. We'll also be using all the new techniques and technologies, as you'd expect, because in health we've probably been a bit behind our commercial partners in really embracing the opportunity that big data and advanced analytics actually brings us in this area. Joining data together is actually at the heart of this. Understanding pathways of care and bringing disparate systems and services together is what we'll do. And we'll do that by building strong relationships with academia and commercial partners. And we'll do that actually not just working together across all of those partner organisations, but also working with our patients and public, because actually ensuring they have access, you have access, we have access to our own health and care data. That's the only way that our patients will be truly empowered to fully participate in their own health and care. So enabling patients to add to their own record, to share that information and to interact with health and care services in a way actually we take for granted in most other areas of our life at the moment. So for me, technology and data are absolute prerequisites for a value-based healthcare approach, and working together across sectors and agencies to use the data, invest in our systems, connect our systems, services and organisations and individuals together through data. So thank you. They were my kind of reflections. I'd like now to introduce Judith Paget, who is the Chief Executive of Aneurin Bevan Health Board. Thank you.
Bore da pawb, good morning everybody. Thank you for the invitation to participate in the conference today. Just hope to give some perspectives from one health board in Wales. Just one example, there is great work going on within health boards and trusts across Wales. In preparing for the session, I sort of went on a bit of a reflection in terms of the health board's journey with value-based healthcare, which started in or around 2014-15, I think, when Alan was our finance director and came back from Harvard, having listened to Michael Porter intensely around his work. And we started to explore locally the feasibility and impact of measuring outcomes and costing patient journeys. We appointed an assistant medical director at that time, whose whole responsibility was to try and lead the work on value-based healthcare for our health board. And that was a pivotal decision for the health board. And as it turns out, it was a pivotal decision for NHS Wales because the person we appointed was Dr. Sally Lewis. However, we subsequently developed a formal strategic alliance with ISHOM, the International Consortium for Health Outcomes, and started to pilot some work in one clinic, a Parkinson's disease clinic at the Royal Gwent Hospital. It was quite an adventure, and Sally will probably tell you the story of that sometime if you have a chance to talk to her about it. But there was huge learning from that just one piece of work, and it led to growing clinical interest across the health board in value-based healthcare. Over the next year, we started to build a very small corporate programme team, did some global benchmarking with ISHOM on eye care, extended our local work into dementia care services across our system, and also procured a new digital platform, Dr. Doctor, both to collect data, and Helen's just talked about how important data is, but also to communicate digitally directly with patients, which turned out to be so important and has continued to help us through the COVID pandemic as well. The programme developed within the health board over the next couple of years. We added clinical conditions to our work programme. We built it up to over 20 in the next 2 years. And we've continued to consolidate the work and continued to progress that until COVID came along and caused quite a bit of disruption with our great value team dispersed across the organisation. But they're all back together now, and so the work has started again. But even through the pandemic, some of the things we'd learned through value-based healthcare and some of the things that we'd put in place, like the ability to contact patients individually, proved to be really helpful. Why value-based healthcare for us? Well, I think, as Alan has said and others have commented on, the healthcare context and the challenges we are facing mean that value-based healthcare, we believe, has got a really important contribution to make. But also as a health board, we have a very clear ambition to work with partners to produce that, to improve the health and well-being of our population, but also deliver the best possible outcomes for patients. And you can't know if you're delivering the best possible outcomes for patients unless A, you collect your outcomes, and B, you ask patients what's important to them. So in short, we started this mission, and clearly one of our aims is to meet the needs of our communities whilst avoiding waste. Interestingly, in the very early days of value-based healthcare, we did have a lot of conversations with people about what does that value mean? Does that mean we're trying to do things cheaply? But it didn't take too long to achieve an understanding across the organisation that actually this approach would mean that we can influence the direction of the resource to where it creates the greatest improvements in patients' outcomes and their experience of care. And clearly this meant capturing clinical data, capturing patient outcomes, as well as the costs of our service. I think one of the things one of my colleagues mentioned was that, and we've seen this as well, we've been really impressed by how the work on value-based healthcare has brought clinicians, finance and service managers together. They are, of course, always united in their dedication to service and patients, but this work has enabled them to review data together, to seek to understand together, and to problem solve together with safety and outcomes as a core purpose. I think the most important thing to say about our approach in an Iron Bevan is that it's the clinical teams that invite our small value-based healthcare team in to work with them on pieces of work. It's clinically initiated, it's clinically driven, it's not mandated by the health board. It's really driven by the clinical teams themselves. And over time, our value-based healthcare team has refined its approach. It's got a really good 5-step model now that it takes in to work alongside clinical teams, and it has developed a more practical toolkit that it's published and is made widely available. I think working through each step in a patient's care pathway has enabled a view about how each step adds value, and cost in each step, raising awareness about the cost of each input. We've developed our in-house capacity and capability for costing, and that's been a really important part of the journey. Helen's mentioned technology, and it's been mentioned a few times, I think. It has been absolutely critical in data collection at a patient level, but also at a programme level, a service level and a pathway level. And what's been really important to us has been ensuring the collection of patient-reported outcomes is seen as an integral part of the patient's interaction with their clinician. The completion rate has been high. Patients really appreciate that clinicians are using PROMS data. PROMS is helping us and clinicians stratify patient groups to optimise care. Patients tell us they feel more involved in their care as a result of the contact with clinicians in this way. Clearly, the clinicians have had great insight into patients' views about what's important to them and into patients' outcomes. It definitely has improved the efficiency in many service areas, but it's also improved our effectiveness. We are now providing models of care with lower cost and improved clinical outcomes, which is really, really important, and the scope to do more is great. Professor Chris Jones mentioned COVID and the COVID world and how important value is in the COVID world, and I absolutely agree with what he said. The suspension of elective interventions through the pandemic now means we've got significantly higher numbers of patients waiting on elective lists, and the traditional approach of just increasing capacity is no longer going to be a short-term solution. It's just not going to be a good use of resources, and it's definitely not going to achieve good outcomes for patients. I think what we've seen is that there is now a natural window of opportunity to make some changes. I think COVID has also influenced people's behaviour. We've seen changes in the way people's attitude towards things, a really strong can-do attitude, a more open way of doing things differently and considering alternatives. And the risk to some patients from COVID has become greater. Therefore, doing what matters to patients has become magnified. I think as well, the technology that we've put in during the pandemic, the amazing work of our information and technology teams has created technologies that are now available to use. And I think also the greater focus on prevention and good population health, good public health, and what matters to our population has also been brought central to our conversations during the pandemic. So probably in my view, when I think there's never been a better time to apply the value-based principles and make it central to how we maintain and improve the health of our population, make better decisions to support patients and make better use of our resources. I think we've learned a lot over the last few years. I think the opportunity in Wales to really continue to put value-based healthcare central to what we do in the post-COVID world is absolutely really important. Hopefully, and that's given you a little insight into what we've been doing in Eira and Bevan. I'm now going to hand over to Carrie-Anne Quinn. Carrie-Anne is the Chief Executive of the Life Sciences Hub in Wales. Carrie-Anne.
Thank you. Good morning. So I'm delighted to have the opportunity to be part of this opening session for the Value in Health Week, and it's great that the organisers have been able to create this this series of events to celebrate value-based healthcare adoption here in Wales. So we were disappointed not to be able to have the international conference in November, but absolutely delighted to see that we've been able to bring so many people together for this celebration this this week. So my organisation is a wholly owned subsidiary of government that's tasked by ministers to work with industry and academia to support health and social care service delivery. So we're encouraging the development and adoption of innovative products and services. So I guess against that backdrop, my involvement today is to consider the role of the Life Sciences Hub to support industry partnerships in value-based healthcare. So each of us, whether we work in health, industry, academia or government, are all exploring new ways to develop, deploy and adopt innovation. And from my perspective, the value-based approach provides an opportunity to support product adoption and achieve systematic change on a pan-Wales basis. So if we consider that value-based healthcare in Wales can be regarded as a method for achieving the best possible outcomes for the needs of patients through the optimised allocation and utilisation of resources, it really gives us a strong framework to think about how we're bringing products and services forward and what benefit and evidence that is providing. And such an approach will require the whole system to get involved. It will pay attention to quality of life and outcomes that matter most to patients. But this can all only be achieved if all parts of the system are working collaboratively, and I see industry as a key partner in this. So therefore, it's going to be critical that industry understands the value-based healthcare approach that's being developed here in Wales and is able to use the same kind of language and to consider its products against this backdrop and against the lens that our health service is considering and attributing value to our activities. So the Life Sciences Hub Wales, we think, are perfectly placed to support this collaborative approach, which should really include the application of innovation, spread and scale, should look at behavioural change and really embrace the value-based principles. So we work with life sciences businesses to develop and co-develop and collaboratively approach products and service development that will maximise the value proposition. And we work with individual industry partners who are keen to understand how they can improve their offers and interaction with the healthcare system in Wales. And it's by working in partnership with industry to allow this honest appraisal of evidence from ongoing data capture once new products and services have been adopted, and really using this as a basis to inform future activity. It really is a new way of thinking about how we're engaging with industry and bringing products and services forward into the healthcare setting. Just listening to my colleagues this morning, you know, Helen's already described that one of the keys to achieving this is to embrace digital technology, enabling greater communications with patients and building on some of the great work that we've seen over the course of the last 6 months in development with the digital infrastructure right across the NHS. Industry has a key role to play in supporting that digital agenda, and actually by working in partnership with the National Value in Health team, procurement and academia, we can all provide a consistent approach to value-based healthcare that develops and supports a consistent language. And I think my reflection is that consistent language is key to ensure that we're using the same terminology and the same understanding across clinical pathways when we consider outcome measures and as well as how we approach procurement challenges. So this will really support the benefit realisation of the value approach and consider the experiences of patients and improve our resource utilisation in addition to supporting industry and supporting sustainable industry growth locally. So by working collaboratively, we can all move to, I guess, a more person-centred care. And we're absolutely delighted today to advise that we have more than 80 companies from right across the life sciences sector signed up to this Value in Health event. And it's a fabulous indication of the importance that value is being given right across the sector. So we've seen a lot of activity across the pharmaceutical industry and wider life sciences sector that's already demonstrating significant interest and significant new ways of working across value-based healthcare. There are also opportunities to identify and co-develop innovation solutions using medical technologies, biotech, informatics and wider digital solutions to more systematically capture, collate and analyse the use of outcomes and experience data. So for example, early and accurate diagnosis, allowing prompt, effective treatment, which is extremely important, is producing good outcomes for patients and supports precise and individualised treatments. And it's the use of data to inform pathways designed at both an individual and a population level that will be essential for the delivery of value-based healthcare. And when value is maximised through tailoring treatments to individual needs, we're improving the outcomes as a result and allowing the system to focus its resource where they have the greatest impacts. So for me, events like this are really designed to inform, educate and engage with industry against the value-based healthcare agenda. This is really, you know, a start of a journey for us to work with industry as a whole, to embrace the way that the health system in Wales is considering value. And in a publicly funded health system, industry must be a critical partner, working with NHS Wales to achieve the best possible outcomes for the needs of patients and working together to do the right thing at the right time. And it's incumbent on all of us, I think, to work collaboratively to achieve that aim. So to support this really exciting opportunity, this year the Life Sciences Hub has identified value-based healthcare as one of our key priority areas. We've established a team within the organisation that will work directly with industry to align with the aspirations of the National Value in Health team. And I really do look forward to working with you all to embrace this remit so that we can bring forward products and services to maximise the outcomes for benefits of patients. We've really seen over the course of the last 6 months how the pandemic has driven a new focus for the adoption of innovation and new ways of working at pace. New products and services have been brought forward at breakneck speed, recognising that, you know, when organisations from different parts of the service and the system have a shared vision, that they can really come together and really work collaboratively to impact patient outcomes. And now feels like the right time to absolutely embrace that way of working and align with the value-based healthcare opportunity, and we can all work together to really make a significant difference. So those were my reflections of value-based healthcare, recognising that we're on a start of a journey to really look at working with industry at pace and scale, looking at spread and scale on a national basis. Yeah, I'm asked now to hand you back to Sally, where I think we're moving into the question and answer session. Thanks, Sally.
Thank you, Carrie-Anne, and my thanks to all the speakers this morning. So, to summarise, what's the problem we're trying to solve here with value-based healthcare? A few years ago, when I was working as a full-time clinician in general practice, one of my constant frustrations was seeing that resources weren't perhaps always allocated optimally to ensure the best outcomes for our patients. And that's not because there's a lack of will in doing that, it's just sometimes needs are less visible to the system, and it's harder for us to direct our resources to where they have greatest impact. And of course, there's a lot of competition for those resources between differing needs. So how do we ensure equity across service provision for all needs across our region and across the world? And of course, we're all facing the same issue of rising costs, and mostly it's new technologies that are driving those costs in healthcare. new medicines, new devices, digital health, all for the good of our patients. So we have a duty to ensure that the technology that we introduce truly is delivering value for our patients through improving their outcomes. And of course, health is wider than healthcare, much wider, and most of our health is generated by other things in our environment, our working environment, the economy, leisure, and so on. And so we need to work with partners outside of health to ensure that we have a flourishing population, as one of my colleagues calls it. So why does value-based healthcare help, and why is it necessary? Well, it's not a panacea, it's just a tool. It's just a tool to help us deliver the best outcomes that we can equitably for our population with the resources that we have. And that's always a challenge. And it requires a mindset to collaborate, as our panel speakers have eloquently illustrated this morning, and that common language that Carrie-Anne was just mentioning between clinicians and finance, but also managers, policy and informatics, to bring together all of the skills with patients to truly deliver the greatest quantum of health that we can for our population. And I know that that is an aspiration for all of us in Europe and indeed around the world as we implement value-based healthcare. Data-driven decision-making at all levels is critically important. It doesn't matter whether we are talking about supporting individual patients with shared decision-making in the consultation. We need to present patients with the right information so that they can make the best decisions about their health in their own context so that they meet the goals that matter to them. We need to supply information to the service so that we can instigate quality improvement and see how we improve outcomes within the service. As Alan mentioned earlier, we need to understand how to allocate resource across subpopulations so that we can make sure that patients have all the tools they need to improve their outcomes, no matter what their condition. And finally, we need to be using larger data sets for research, for collaboration with industry, to make sure that we are driving value in technology, as has already been mentioned. So now we need to move into our question and answer session. And we've had a huge number of questions submitted prior to the session, so thank you for that. But my first question today, I think, is going to be for Helen. Given the importance of data and digital, upskilling, I think, is a really important issue, isn't it, Helen, in digital health? Do you think there's enough understanding of digital at a board level across the university health boards and trusts, and indeed generally across the UK and Europe? And what can we do to address that and upskill everybody so that they have a full understanding of what is required to deliver digital health?
Thanks, Sally. I think it's probably fair to say that healthcare has lagged behind. Kind of when you reflect on the technological advances we experience and expect actually as part of our health and care services, actually the digital and informatics and data side of that, I think, has lagged behind industry, and it's lagged behind in terms of investment and probably in terms of ambition. I think the recent we've been on a bit of a journey, but I think the last kind of 7 months or so, where we've been in response to COVID and really has pushed that agenda, it's pushed the boundaries. I think as a system, as individuals, I think our expectations have been raised. I think our experience has now taught us that actually digital and change enabled through digital actually doesn't have to be as scary. I think our tolerance has increased because we've had to get on with doing things differently, actually, because that's what that's the situation we've found ourselves in. So I think actually digital has probably been one of the good news stories, if there have been any, that has come out of the response to COVID. I think particularly around the board level appreciation, I guess, of digital. I think that's been a challenge previously. I think we're now seeing that digital as an enabler to transformation and to sustainability of our services is now better understood. I think we're seeing more organisations put senior director level roles around the board table to actually bring the digital conversation to the board level discussion, which we hadn't seen for some time. So I think there's a lot more that we need to do, but I think actually we're seeing quite a real improvement in that area. And I think with the establishment of a new special health authority to lead on digital for the NHS in Wales, I think that can only get better, because we'll keep this on the agenda and keep talking about it.
Thank you, Helen. That's very helpful. Judith, I wonder, as a board member, do you have any reflections on that?
Yeah, I mean, clearly, absolutely support that view. I think, as I mentioned in my introduction, I think making sure that data is available, captured, and drives what we do it's hugely important. I think, as I said, at a local level, at a patient level, having that data for individual interaction is essential, but building it up through services, programmes at health boards, and then having the ability to compare and contrast not only in Wales but internationally is so important, because there is so much learning that is generated from that. And if we are going to pursue improvement in outcomes and improvement in cost, being able to learn from each other and share what we've learned, but also compare and contrast what we've learned is critical, and data is fundamental to doing that.
Thank you, Judith. And while I have you on the line, I have a question here asking, how do we ensure that we adopt a shared value-based approach that's truly across the whole system, so across primary care, community services and secondary care?
Yeah, thank you. I think probably the approach to that needs to be at different levels. So I think, firstly, to say I think we've got a huge opportunity in Wales around value-based care in a unified system, and in some ways our system in Wales, our system of care, is fairly straightforward, and so therefore I think coming at this from a number of levels might be the right approach to the answer. In terms of policy, clearly Welsh Government is fundamental in making sure that value-based healthcare is a golden thread that's weaved through the policy direction emanating from Welsh Government, not just in terms of health, but social care, the public sector, and creating that sort of context, I suppose, for that to be pursued. I think I can give you one example of that. The National Strategic Programme for Primary Care has got clearly a national architecture around that, and clearly a number of key elements to the programme. But one of the threads that underpins that programme is about value-based healthcare, and one of the tests that we apply to the work of the Strategic Programme for Primary Care is to make sure that the work that's being produced and guided through Wales meets the principles of value-based healthcare. So that's one. I think at a more local level, I think health boards through their IMTPs must clearly set out and articulate their direction of travel around value-based healthcare and create that local context where outcomes and value are really important to what they do. I think pathways across our systems exist, and bringing people together to talk about those pathways, understand what's adding value, what isn't adding value, and being absolutely clear about the costs of various inputs on that pathway is fundamental. So creating that opportunity at a health board level is important. But I think at an individual level, We need to just seek to have those conversations. We need to find people to talk to about what's happening. We need to engage patients and carers in those conversations to find out what's important. And we need to be reflective, and we need to be open to hearing things that we might not have expected, and views on services and what's important to patients and carers that we might not have prioritised or thought important ourselves. So I think there is something about creating a culture as well as creating the mechanisms that allow that to happen.
Thank you, Judith. My goodness, the questions are coming thick and fast now. What I would say is we won't get through all of the questions in the Q&A session, but what we will do is endeavour to provide written answers to all of the questions in the coming week or two. So if you don't get your question answered today, you will get an answer from the panel shortly. So I'd like to move to Alan now, if I may. Alan, I've got two questions for you, really. The first one is, in a traditionally cost-driven system, how can we change behaviours towards true value creation so that cost reduction is kind of a byproduct rather than, you know, arbitrary cost cutting?
Thanks, Sally. Let me start by just probably disagreeing with that. I think I understand the feeling that we are a cost-driven system. But if you sit down with any clinical team, the thing that they probably are the least cited on is the costs of the decisions they make, the costs of the care they provide. And that's probably because a little bit of what I described earlier, if you think about where we probably concentrated our efforts, it's in those more traditional areas of cost improvement or cost reduction. Can we get supplies cheaper? Can we sort of cut our input costs? Can we procure things differently? And I think we've sort of, we do too much of that. It's important, and you've also, when you're spending public money, you've got to make sure that you, you know, always sort of look at value for money. And we've moved more into operational areas about sort of our theatre productivity, how we use our hospitals, and increasingly looking outside hospital care. But the thing we haven't really done is work really closely with clinical teams and actually joined up some of our measurement and our language. A lot of clinicians do not understand the world of finance. We invariably talk about their service being more expensive than another comparable service, and that absolutely just switches people off. The thing that everybody who works in healthcare gets out of bed on a Monday to do is to provide great care to the communities they serve or to their patients. So we've got to start connecting the measurement of outcomes and costs at that level. And we've got to make some of our measurement much more meaningful. Some of the theory that has come out of Harvard about using time-driven activity-based costing, I found is hugely helpful when you sit down with clinical teams. People understand the value of time. And in a workforce where increasingly workforce availability is our problem, how we use people and people operating at the top of their license, only doing what they can do, is really, really important in both the way that we use a scarce resource, or an increasingly scarce resource, but more importantly, how we understand the costs and the decision making of what we're doing. And I think if we can talk about the opportunity to improve outcomes, and we can talk about the opportunity to use people differently, and some of our measurement of costs translates to that, it very much becomes a change process that is led by clinical teams. I think where they see the opportunities to improve outcomes and to improve the way they use resource, and particularly money and people, then they change themselves, and that's often the best type of change, rather than this top-down, target-driven, you've got to save 3%, which I think increasingly in the world that we're in, it just absolutely switches people off. It doesn't connect with why people turn up every day to provide good healthcare in Wales.
Thank you, Alan. And the second question, which I'd like to address to you and then perhaps to Chris, is from some of our colleagues in Europe. And we're being asked, what, from your perspective, are the key lessons that we've learned in value-based healthcare implementation so far that European partners could learn from? So Alan first, and then Chris.
Thanks, Sally. if I start with just that notion that everybody seems to agree that the way we currently plan, manage and deliver healthcare needs to change, we've got quite a significant change ahead of us, and you know, we talk about the need to change as if it's easy. Change is really difficult. Change is a hard thing to do. People struggle with change. So there are a couple of things you absolutely have to have in place at all levels, whether you're talking about a system like Wales or whether you're down at a clinical level or a clinical team level. And that is, there's got to be some sense, some sort of vision that that there is something better that we can be doing, that people buy into. There's clearly got to be a sense of urgency. I think, you know, let's not underestimate the fact that, you know, with busy the busy worlds of healthcare, health and social care delivery, it's really difficult sometimes to actually just sort of lift your head and actually begin some of this change process. You know, it's very easy to just get sort of immersed in the doing. So there needs to be some driver that things can't carry on as they are. And then the third element, just in terms of generalized points, is you need enough people or enough key people to want to stick with some of this change and break down some of the obstacles. Because if you start from the premise that change is hard, people really have got to stick at some very difficult sort of times to make sure that they get to a better place. And then at a very practical level, I think, you know, what I've certainly found, and I think Judith referred to it in an Iron Bevan, is, you know, what gets measured gets done. So you've really got to be quite deliberate about sort of recording both outcomes and costs at all levels. So recording and then reporting it, making it very visible. I think the more visibility you bring to some of the outcome data and the cost data, the quicker the change goes. I think the point that we sort of touched on, and you made the point, Sally, around primary care, you've also got to reward the right things. I think nothing switches people off where they're doing some really difficult change, driving some great outcomes, but the money seems to be going to the wrong things. So we've got to make sure that we reward some of the right approaches and the right delivery. And then there's a bit that I think increasingly we come to at a system level particularly, is you've got to regulate the right things. If you've got a regulator or any regulators in the system constantly focusing on the wrong areas, then you will have some fairly significant disconnects. So there's some general points about how do you drive change, but there's some very sort of specific things about just getting going. And as I think Judith described, the more you do, you arrive at a tipping point where it has its own momentum. Everybody understands that these are the things they want to do.
Thank you, Alan. And could I put that same question to you, Chris?
Yes, thank you, Sally. I mean, it makes me reflect a little bit on medical practice, and whether medical practice has, in a way, gone too far down a sort of interventional, inputs-based approach to people. I think up until recently, we've probably felt that the more we do to people, the better clinical care we're providing, the more maybe tests we do, maybe the more diagnoses we make, maybe the more tablets that somebody ends up on. Somehow that's very high quality care. But actually, I think quite often we've lost sight a little bit of the person and why they came to see a doctor, because there are problems associated with a lot of this. If you arrange a lot of tests when a frail elderly person goes into hospital, then those tests are sensitive tests and they're likely to find problems. That's likely to generate further assessment or intervention. It's likely to increase length of stay. A lot of these interventions are quite harmful. And actually, I think in the end, the easiest way to increase value is probably to reduce unnecessary costs. And I think value-based healthcare helps clinicians realize some of this. It helps them understand the costs that they generate and actually helps people reflect. It's like holding a mirror up to the medical profession. Somebody in the sidebar earlier talked about the Caring Act. And I do think, we're all aware that there is a challenge of compassion in our healthcare provision. And I think it's quite easy to understand that when one sees how complex healthcare has become, how technical it's become. And actually, it's no wonder really that the holistic needs of the person may somehow have become secondary to the process of delivering all this care. We do deliver industrial amounts of healthcare, but it's basically all generated by the decisions that clinicians make. And I think that to start to demonstrate those costs holds a mirror up and helps the clinical community, maybe the medical community in particular, realise that maybe it's gone a little bit too far in its pursuance of evidence-based medicine, perhaps leaving the needs of particularly our frail elderly people behind. Probably most of them would rather just be returned home, provided that they're able to live independently. But a lot of what we do against that outcome.
Thank you, Chris. And could I follow that up with a question then about the curriculum for healthcare professionals generally, not just doctors? How do we get a greater awareness of the sorts of issues you just mentioned, right from training and early career? Yes,
I think quite a lot of undergraduate medical education is still specialty driven, probably still undertaken in hospitals, still with a big focus on evidence-based medicine and statistics, and all of that's entirely appropriate. But there does need to be a more holistic content as well, even a better ability to take a social history, to understand in a way what family support or social support an elderly person has, or what community support there may be available in a certain area. We're not aware enough of this. We still bring a medical lens to this. We try to convert somebody into a list of medical diagnoses. That's the clerking process. And I do feel we've got further to go. I understand that these are difficult cultural behavioural issues to unwind for a profession, and that a lot of people will be fearful of doing less because they would fear legal challenge or complaints. But again, I think the answer there is communication, is actually to explain to people and to families, in a sense, what may be important for a person in our care, to explain the options and the disadvantages of those options, quite honestly. Maybe we're not all that good at understanding individual risk and individual benefit. So I do feel a more holistic approach with a more social emphasis, particularly in the very elderly, and a broader perspective than we have at present is needed. But it is difficult because getting into medical school is a very competitive process. People tend to be academically high achievers. That competitiveness selects medical students, and that competitiveness drives us through our careers. But maybe it drives us in a way that hasn't always met the best needs of our frailer, more vulnerable populations.
Thank you, Chris. Yes, there's a huge cultural element to this, isn't there? Carrie-Anne, I'd like to move to you now, if I may. We have a question about industry and the relationship between the healthcare system and industry has been fraught, really, hasn't it, with mistrust. But we certainly do need industry, as it's industry, after all, that innovate and create the new technologies which allow us to make such great advances in medical care over the years. So how can we overcome that mistrust? How can the private sector unlock some of the barriers to allow value-based healthcare to deliver outcomes for the citizens of Wales?
Thanks, Sally. No, as you say, the private sector is inherently innovative. and they're focusing on the development of more effective products and services right across the healthcare sector. And we really must remember that these industries have experience of working across other health systems. They're a really strong font of knowledge and experience across international systems that really here in Wales we could benefit from. But as you say, one of the key barriers that has been faced by industry is really in relation to working in that trusted, co-creative and collaborative environment that we're seeking to encourage to support a value-based approach. And I think that whilst this may be a new way of working for some organisations, actually this move to an evidence-based structure is critical to start building that trust. And you know, as we talked about earlier, where we can start developing a common language and a common use of terminology, I think that communication between industry and the health system improves significantly. We talk to companies a lot about the use of health economics, ensuring that when industry is bringing forward new exciting technologies and products which will focus on driving efficiencies and a focus on driving improvement, that they're using a language that is of benefit to the health system. So it moves away from the initial conversation maybe being transactional and just focuses on outcomes and how those products and services can really transform the lives and the treatment pathways of people in Wales. But it's really about using that consistent approach, both in terminology and language, so that we can all learn and develop solutions and build those pathways moving forward. I really do feel that in recent months, some of these barriers just seem to have fallen away, and it was the development of that shared vision that has really made a difference in the way that approach has been embraced and has been developed, and we've really got to build on that momentum, and I think encourage the very open and honest dialogues that we've seen developing across the organisations to really take new ways of working forward. And actually, you know, this event is the start of that journey in very many ways. We've got a strong number of industry delegates with us today, as well as colleagues from right across the health and social care framework. Hopefully all hearing the same approaches and just a new way of working that they can embrace. And we're really keen at the Life Sciences Hub to be really working hand in glove with industry, to be guiding them through this journey so that we can understand the barriers that they're facing, work with them to address them, and enable them to have a clearer pathway that can allow their innovative products and services to be utilised and are taken up across Wales nationally.
Thank you, Carrie-Anne. And gosh, the time's flown, so we are actually coming to the end of the session now. There's been a lot of comments and questions regarding practical implementation, and I couldn't agree more. This is not just about talking about value-based healthcare, it's about doing it and unblocking some of the barriers and problems that prevent us from achieving value for our patients. I would commend the week's programme to you in terms of demonstrating practical implementation techniques across all of the disciplines, but I want to give Judith the last word on this, as probably the person that's had the most experience in observing practical implementation within a health board, and give us your final reflection on that, please, Judith.
Okay, thanks, Sally. Just a couple of points of reflection from me. So getting good executive leadership and board support at the beginning was really important for us. We split the leadership portfolio across the medical director and finance director, which in hindsight was absolutely the right thing to do. Getting good clinical engagement was important, but we started with the enthusiasts. and it didn't take very long to others to come forward with ideas and wanting to join. I think being clear about why you're doing this at the outset is really important, and communicate that as widely as you can. For me personally, I really wanted the health board to design care around the needs of the people who are actually going to use the care and have the care. So patient reported outcomes and family reported outcomes, really important. Start small. It's difficult to know where to start. Somebody once said to me, we're thinking big, but we're starting small. And I always thought that was a really good way of describing it. And yeah, data has been mentioned a few times. We really have to, and did, and continue to get a grip on the data.
Thank you, Judith. And so that concludes the opening session for Value in Health Week. My sincere thanks to the panel for their insights this morning, and thank you very much for joining us. I hope you will enjoy the events throughout the course of the week and hope to see you again soon.